Well, thank you very much. I've been asked to talk about scoping a degenerative knee and what factors affect my decisions to recommend that to patients. This is where the art and science of medicine really collide, and also where our experience and the evidence may collide. Here are my conflicts. So I look back on my SNE scopes over a 10-year period, and as you can see, there's been a significant decrease in the number of meniscectomies and an increase in meniscus repairs, even repairs of this horizontal tear on the right. Video is not running, but maybe it will. I'm also doing a lot more injection therapy for these patients in my clinic. This trend's national, and the ABOS data reflects it, with decreasing amounts of meniscus surgery in general, meniscectomy, and an increase in meniscus repair. This is probably a really good thing for our patients. This trend's been going on for about 12 years and started in 2008 in the United States when meniscectomy was devalued by CMS and insurance companies. And this study out of Florida indicated about a 49% age adjusted decrease in knee arthroscopies with a diagnosis of osteoarthritis between 2002 and 2012. Subsequently, several randomized clinical trials showed that arthroscopy and meniscectomy were no better than a sham surgery or physical therapy. Despite their high level evidence, there are flaws in these studies, but they still have many questioning the value of arthroscopy and osteoarthritis. Lots of selection bias and crossover issues here for these studies. One of the biggest flaws is that most of these articles don't include a pre-study trial of conservative care, which I think most patients receive in the real world. Certainly in my office, they do. So we know from our experience that arthroscopy does have value for patients with osteoarthritis, but the evidence is pointing us really in another direction. The AAOS in their CPG from 2013 said they can't recommend for or against arthroscopy and meniscectomy in the setting of osteoarthritis. And this is just about to be revised, so I'd ask everybody to look out for the new guideline. Other guidelines are clear, but they fail to recognize the value of arthroscopy at all, such as this one from BMJ in 2017, with a strong recommendation against the use of arthroscopy in OA for any patients with any osteoarthritis at all. This type of blanket statement moved me to write this editorial. Are we running out of treatments for osteoarthritis of the knee? Based on CPGs and coverage decisions, we can't recommend hyaluronic acid or arthroscopy, but we can do Tai Chi. That's not really too helpful. Despite these CPGs, many of us are still performing arthroscopy in the setting of osteoarthritis, even within 5 years of total knee arthroplasty. So what's going to guide us here? Well, there's really better guidance comes from Europe. ESC has published this guideline and recommends that these patients should all have a trial of non-operative care, perhaps with exceptions for age or mechanical symptoms. They recognized higher grades of OA, a BMI over 30, female sex, meniscal extrusion, bone marrow edema, and previous subtotal meniscectomy as poor prognostic indicators. This study looked at arthroscopy for degenerative and traumatic tears in patients with OA who all had 3 months of physical therapy and failed that, and found no difference when these patients were treated arthroscopically. They similarly found female sex, lateral meniscus tears, higher BMIs to be poor prognostic indicators. What do I do in my practice? Well, first of all these patients receive a long discussion of the natural history of osteoarthritis and all the treatment options available to us, including activity modification, medications, PT, injections, orthobiologics, and arthroscopy. And then in general, we'll start with less invasive treatments and work toward more invasive ones as we need to. I go with injection therapy early because these patients are really looking for immediate relief in my office. So if they have an effusion, I'll recommend a steroid injection and physical therapy. Without an effusion, I'll recommend hyaluronic acid for lesser grades of OA and steroid injections for higher. When and if these treatment fail, we'll recommend long-acting steroids and discuss PRP and other orthobiologics and arthroscopy based on KL grade. I really prefer not to scope knees with KL 3 or 4 or more advanced osteoarthritis with lateral meniscus tears, meniscus extrusion, a BMI over 30, or anybody who presents with subchondral edema. Really, this is where the art of medicine is. This is where you need to pick the right patient and the right treatment for them. All these patients should have a trial of conservative care. How long is up to you and your patient and should be tailored to the patient. Arthroscopy does have value for patients who fail conservative care with the usual caveats for sex, BMI, laterality, extent of disease. But I think the best advice is to treat these patients as individuals and develop a treatment plan based upon a shared decision-making, which is the real art of orthopedics. And thank you very much, and great course, guys.